Well, let's get started. Okay, good afternoon, everyone, and it's my distinct pleasure to introduce our grand round speaker for the afternoon, someone who's no stranger to us, Dr. Mauricio Tohen. Dr. Tohen is a university distinguished professor, Regents Professor, McLean Endowed Faculty in Bipolar Disorder Research, and Chairman of the Department of Psychiatry and Behavioral Sciences at the University of New Mexico in Albuquerque. He was born in Mexico City and attended the Faculty of Medicine at La Universidad Nacional Autónoma de México, UNAM, the National Autonomous University of Mexico. He completed residency in psychiatry at the University of Toronto and a fellowship in psychopharmacology at McLean Hospital, Harvard Medical School. He also obtained a doctorate in epidemiology at the Harvard School of Public Health and a Master of Business Administration from Indiana University. The impact of Dr. Tohen's work has been felt widely. In 2014, Dr. Tohen was recognized in Thomson Reuter's The World's Most Influential Scientific Minds. That is, he was one of 100 scientists worldwide recognized in the psychiatry and psychology category. Dr. Tohen has published over 400 articles. In 2016, the International Society of Bipolar Disorders awarded him the Mogens Schou Award for Education and Training. In 2017, Dr. Tohen was recognized by Expertscape as having the top 0.12% expertise in bipolar disorder worldwide, based on citations of published articles between 2007, 2017, and between 2010 and 2020. In 2024, Dr. Tohen's total citations added to 40,814 with a D-index of 106. Dr. Tohen is the current president of the American Association of Chairs of Departments of Psychiatry. Safe to say, Dr. Tohen has been quite busy in his career. Thank you, Dr. Tohen, and I will turn over the video conference podium to you.
Thank you for the introduction, Dr. Varela. And colleagues, great to see you all. So as you can read, we're going to be talking about early intervention in bipolar mania. This is an area that I've been involved back to my early stages in my career when I was a doctoral student. In fact, my doctoral thesis was on this topic, an outcome in mania. So I've been doing that for quite a while now. And of course, including being able to take care of our patients. So thank you all for being here today. So why don't we get started? So these are my disclosures. There was a time that I was an industry scientist, so I was designing studies in bipolar disorders. So I still advise pharmaceutical industry or other entities in terms of research design of studies in bipolar disorder, as you can see on my disclosures. And by the way, today we're going to briefly talk about treatment, but most of it is going to be about outcome. So let's start with a review that appeared in the American Journal not that long ago, looking at early intervention in bipolar disorder. So I'm going to give you the highlights of what is in that article. Number one is that in medicine, we should aim to prevent rather than just treat. That really should be a goal. Prevention should be the goal. In psychiatry, we struggle. One of the main reasons is because the etiology of the conditions we take care of is not clear. So that makes the prevention a little bit more complicated or more difficult to achieve. Other areas of medicine like cardiology or oncology, they have moved into early intervention quite successfully, especially in the last years. But in psychiatry, unfortunately, we still focus on reducing the consequences of the condition. And instead, we should only be, well, not only, but we should be focusing on preventing, and not just preventing for ideally, for this disease not to occur, but actually preventing the worsening of most of our psychiatric conditions have a downhill outcome. So that is an area that has been a area of interest to me, and we're going to be focusing on that today. So, why does it matter? As we know, major serious mental illness is quite prevalent, and it causes a great degree of disability. As most psychiatric conditions, it appears at early age, so it affects young people. It doesn't go away. It actually, with time, in many cases, it actually worsens. So that's why the importance of early intervention, because that way we can improve the lives of our patients, their families, and for that matter, society in general. So as mentioned, bipolar disorder is a progressive condition. That means it starts with a prodrome. Usually when we think about prodrome, what comes to mind is schizophrenia, but bipolar disorder also has a prodrome, and it can go back 10 years. So it can be identified at early stages. Usually it's milder symptoms of the condition. They appear before the full criteria are met. Something that we should pay attention to in terms of prevention is not only think of prevention at the time the condition has fully appeared, but even in the early stages. Now, the age of onset varies, but in general, it is adolescence and up into early adulthood. However, there's a very late onset mania and over 65, and we've worked in some of those outcome studies. But so the majority are it's early, but it actually can appear even after age 65. And of course, the earlier it appears, the worse the outcome. And there might be a few factors here. One could be is that more severe conditions have an earlier age of onset. The other one is that in terms of the functional outcomes, so many times when the condition appears, in the case of bipolar disorder, the individual is not able to complete their education or start working and so on. So that will mean that their lives will be affected in different ways, including not being able to get their education. So without intervention, the consequences are quite severe. And there's also some interesting data that in terms of early intervention is not just psychosocial intervention, which are key, but also pharmacological, and that the intervention actually might have some effects in the neurobiology. So it's not only the functioning. There's some studies that show that actually the neurobiology of those with the condition changes as the condition worsens. So let's look at some of the prodromal symptoms. It is usually mood and anxiety symptoms. Also ADHD. Actually, some studies have identified that the prevalence of ADHD, actually looking retrospectively, can be as high as 40% in those suffering from bipolar disorder. So key question is it a comorbid condition, or is it the non-specificity that what is initial signs of bipolar disorder is, of course, hyperactivity. So that is it a separate condition, or it's again that pseudo-specificity, the symptoms? I think it's a combination of both, actually. Trauma, as we know, unfortunately, in our state is quite common, and definitely contributes to the onset of bipolar disorder, not only in terms of the prevalence, the number of individuals. Actually, some studies have shown that the presence or the prevalence of PTSD in patients with bipolar disorder is up to 30 to 40%. So it's, of course, quite high. Other factors that might be considered risk factors: antidepressants, are they risk factors or not? Meaning, if a patient develops mania, after an episode of depression, was treated with antidepressant. Did that cause the mania? I would say no. It contributes, and in some cases, you might even argue that the age of onset was younger because of the use of antidepressants. I think a key thing is the etiology of bipolar disorder is multifactorial, and one of them could be the use of antidepressants. Does that mean we should be careful with using antidepressants with adolescents? Well, the answer is yes, for different reasons. But a very important question when we first see a patient with depression is to ask, is there a family history of bipolar disorder? And that will lead us to making a couple of decisions. Number one, if there is, the likelihood of responding to an SSRI is not that great. And second one, it may contribute to the onset of mania. So good, important point to keep in mind. Substance use. I've mentioned many times that it's more of an exception when a patient with long-term bipolar disorder doesn't also suffer from substance use disorder. A key question is is there some causality, or why is the comorbidity high? Is it that individuals with bipolar disorder use drugs to make themselves feel better? That was sort of the old understanding. There might be a bit of that. The other one is, can substances cause mania? The answer is yes. Actually, at PS, we see many times a patient comes into PS, patient has symptoms of mania. The first question that we ask each other, is there a urine toxic sample or not? And many times we have both. But also in chronic use, meaning primary bipolar disorder and substances, specifically stimulants. But also studies have shown that the chronic use of stimulants, even when they're stopped, they will leave a chronic psychosis that many times is similar to bipolar disorder. So substance use, very high, worsens the outcome, increases the severity, and also would decrease the age of onset. Definitely worsens the outcome. It contributes to instability. So that should be a key target of our early intervention. I'm going to present more data, but you will see that at first episode, the prevalence of substance use is much smaller than after multiple episodes. So that is a key intervention that we always need to keep in mind. And again, I'll be talking a little bit more about that. So this is, we can really do preventive medicine in psychiatry. We can. This is a good example. And and this is another key question. Can we practice preventive medicine when we don't know the etiology of the condition? So we don't really know the etiology of bipolar disorder. It's multifactorial. So can we practice preventive medicine? The answer is yes. And there's some very interesting examples in epidemiology. A very interesting one is tuberculosis. So a preventive medicine or a preventive measure for tuberculosis was started before researchers found out that it was a coccobacillus that caused tuberculosis. This, I believe, is in First World War. And they noticed that when the servicemen were sleeping very close to each other, the degree of tuberculosis, the onset of tuberculosis was higher. So preventive medicine was just separating as the soldiers were sleeping. So preventive medicine happened before the etiology of the condition. So back to psychiatry, we don't know what causes bipolar disorder, but we can still prevent substance use. How? By education. And that's one of the things that we're doing at the early clinic. So briefly, let's talk about some of the biological risk factors. Family history, without any doubt, is it 100% genetic? And the answer is no, because if it were, then identical twins, the concordance would be 100%, and it is not. Identical twins, the concordance is higher than in non-identical twins, but let me repeat, is not 100%, which of course would suggest that the variable is not just genetics, it's one of the variables, but not the only one. Other biological factors, again, it is definitely a strong predictor when there's a family history, and it also affects the vulnerability of the patient. So when we see a patient at PES, a key question when we do the history is, do we know the family history of this patient? And we should, because that will help us predict the severity of the condition. The larger the family history of bipolar, the worse the prognosis in terms of outcome for that particular question. So it's key information when we first see a patient with bipolar disorder. As mentioned, even when we see the patient at PES, when there's a genetic predisposition, that is a family history, the onset of there's an earlier onset in not only in the patient but in the parents. And that, which would be another key question. We see a patient with bipolar disorder, we ask about family history. Another question should be what was the age of the parents when the patient when they develop bipolar disorder, and of course many times we see children or adolescents, so we have the parents in front of us, so we should always ask if it was not them who suffer from the condition, it could be the grandparents. And again, the younger the age of onset in the family, the worse the outcome for patients with bipolar disorder in that family. So there's a high degree of heritability. Again, not 100%, but it affects the condition in terms of outcome and also in terms of treatment. This is another key question when we first see a patient at PES with bipolar disorder, okay? This family history, what was the treatment that the family members received? I say, well, I don't remember. So of course, did they take lithium? So if they say yes, then the next question is key. How did they do with lithium? And if they didn't do well, the chances of this patient doing well with lithium is small. But if the family members had a good response to lithium, that makes that patient a great candidate for lithium treatment. So never forget that question when you first see a patient with bipolar disorder, especially when you're gonna start treatment. So other prodromal symptoms, of course, you see the same symptoms that will become the syndrome. You see them starting symptoms of less severity, and you see them even 5-10 years before the condition becomes clear. There's parents will describe their child as having emotional instability, having mood swings, but going back years preceding the diagnosis. Another very common prodromal symptoms are anxiety and depression. That's another major comorbid condition in bipolar disorders. Anxiety disorders, in fact, it is the most prevalent of all comorbid conditions. And then it would be substance use disorders. And they coexist. It's like what we like to call the trio, which would be bipolar, anxiety, and substance use disorders. So they frequently come together. So that's why the importance also of having a multidisciplinary team when you have different providers be experts or focusing on one area, not the other, but at the end, it needs to be a team. So what we need to avoid is a fractionated treatment team. There needs to be communication among the providers. So the children with high risk, I've already mentioned, those who have high reactivity and anxiety, those who start having sleep problems. Again, that's something that we'd see in families. We're taking care of a patient with bipolar disorder, and of course, parents want to know about the risk of the siblings. So these are some of the things that we start exploring. If there's emotional instability, sleep problems, and that will suggest that the condition will emerge early. This is another time that we can do preventive medicine. Parents will ask us, what can I do to prevent this from happening? I wish there was a way to prevent it, but to contribute in the prevention. The other thing is not to smoke marijuana. That is key. It was legalized. That's fine for other reasons, but it is definitely a risk in our community, in our young community. The younger the use of marijuana, the younger the age of onset in those who are going to develop bipolar disorder. So this is another key point of practicing preventive medicine. And there are other non-specific features of prodromal hyperactivity, as I've mentioned before. Is it a comorbid ADHD or is it prodromal symptoms? And as mentioned, I think it's a combination of both. But having these features definitely suggests risk. So if we look at the bipolar disorder, so you have bipolar disorder here. So you have a genetic component here in red, and then you have a non-genetic component, environmental, and that can include sex abuse. Obviously, we need to prevent that for the obvious reasons and educate our community. Substance, actually, I don't like the term misuse. It should be use. So it's even if it's use in moderation, it still increases the risk. Antidepressants to some extent, as we mentioned. And then what we like to call sort of a dimensional approach, meaning that patients that who have bipolar disorder are going to have other conditions, anxiety, sleep problems, and many times the treatments for one affect the other. An obvious example is when you have attention deficit disorder and you treat with stimulants, can that worsen mania? Yes. Are they contraindicated? No, because it's so prevalent that many times you need to treat both. Just make sure that you share the liability or you share the risk with patients. Yes, I can treat your ADHD with stimulants, but that might worsen your bipolar disorder and even increase the severity of the condition if there is a relapse. Biomarkers, they're not approved by the FDA yet, but there's a lot of studies going on. I'm feeling optimistic that we're going to be able to use them. Actually, a couple of our faculty have been involved in those studies, Dr. Wiley, Dr. Quinn. So this is an interesting area. So they are promising, but they still lack specificity. They have not been approved by the FDA. Imaging, well, imaging in bipolar disorder has been done for many years. It's not ready for clinical use, but definitely studies show not only changes before the condition appears rather, but also see changes when the condition worsens. So yes, at some point, and we use imaging, certainly in the first episode, psychosis, but I think when we are evaluating patients with bipolar disorder, I can see the time not far from now that we will be able to look at the course of the illness and the severity of the condition, not just by observing and listening, but also by brain imaging. That's definitely around the corner. And then activity patterns, circadian rhythms can predict not only, I guess, the risk of the condition, but also an association with the severity of the conditioning. So having digital monitoring, I think, is going to be used more and more clinically. And that will provide indicators that behavioral changes might appear. Right? So again, prevention. So summary to the risk and factors of risk. As mentioned, there's not a single one. It's a combination. And then there needs to be identification of all of those predictors. Let's talk now about, course, an outcome of the condition, starting at the first episode. I always like to say that you have a better understanding of a condition when you start from the beginning. Same as when you're reading a book. You want to start reading the book at the beginning, not in the middle. So to really provide the best treatment, ideally at the onset, and get a history from early on when the condition appears. So I'm going to be talking about some results in a study that we've been doing for a number of years. And we will see that most patients with bipolar disorder actually recover. In fact, it's an exception. And of course, that is great, but it has its risks. And that is definitely a contributor to non-adherence. It's very common that we see at the early clinic patients who recover absolutely absence of symptoms, taking medication. Medication causes side effects, weight gain, restlessness, and so on. So our patients would, of course, is going to say, why am I taking this medication? I'm doing well, and it's making me gain weight. I feel restless. So of course, that leads to adherence. So let me emphasize it. Non-adherence is very prevalent at onset of the illness, even higher than in many cases with chronic conditions for the reasons that I mentioned. Now, when we talk about recovery, sometimes it's ad integrum completely, but not always. There's usually, unfortunately, residual symptoms, and they tend to be more on the depressive side as opposed to on the high mania or irritable side. And that actually affects functional recovery. You know, when we look at not only do research, but even when we're talking with patients about the recovery, the key recovery is functional. Can I return back and be a physician or do work as a cashier or taking care of family, whatever our job is? Are we back to our usual functioning? And many times the patient is not. So let's look at this is recovery. And everybody's here at time 0. That means everybody's ill. It's first episode. And if you reach the top, that means you're recovered. And this is time. So as you can see in this study, the vast majority, more 88% of patients, in the 90s, circa 90 recover. And as you can see, women recover faster. At the end, the rate of recovery is similar than men. Another one that is interesting is if patient stays long in the hospital, will the recovery increase or decrease? And as we can see here is shorter hospitalization, shorter time of recovery. But this is, of course, confounded because we discharge patients once they have improved. So those who stay shorter in the hospital is because they have improved. So this is, of course, a confounding factor. But the key message here is the vast majority of patients after a first episode of mania, and these are hospitalized patients, recover. Now, this is a functional recovery. You're going to see a number of definitions here. We're not going to go into details. Basically, remission is when symptoms are gone and stay gone for at least 8 weeks. Recovery is at one point in time. Syndromal means that criteria of DSM. Symptomatic recovery is when you have the symptoms of mania by using a scale. So there's different ways of measuring symptomatic or syndromal recovery. But the key thing is the functional. So functional means that, again, if you were working as a scientist in Los Alamos, and then you can go back there, but you have to work, say, as a cashier. So that's not functional recovery, obviously. So as you can see, patients might improve both in terms of those syndromes going away or their symptoms, but the functional recovery lags. So that's why many times patients will let us know, can I go back to work? And we have to explore if they're really functioning well. And as mentioned, it lags. The functional recovery lags the symptomatic or the syndromal recovery. Now, once the patient has recovered, what is the risk of relapse? And then, unfortunately, it is common. Again, vast majority recover, but what about the risk of having a recurrence or a relapse? Unfortunately, it happens 40% within 2 years, so almost not quite the majority. And this is actually very helpful that I always share with patients because they're going to ask you, what are the chances of me staying well? So you bring your survival curve, you show it to the patient. I'll show you the survival curve in a moment. But if you follow patients longer, and this study was 4 years, the majority has a relapse, unfortunately. Although it's better than 100%, not everybody will relapse. When can you say patients are free of risk? I would say after 4 years. That was a study led by Wellesley many years ago. That's where the Wellesley Hospital takes its name. And patients were when patients relapse, if they have been in remission for more than 4 years, the chances of relapse were very small, less than 10%. So the longer the patient stays well after the first episode, the better the chances of remaining well. So if the patient gets well with no medication, and of course we know that can happen because it happened in the past, but does that decrease the risk of the relapse? Answer is yes, because if you treat with placebo or with medication, those on medication, even though, let's say, both groups recover, those who stay off medication have a higher risk of relapse, those off medication than those on medication. So we always worry, is the patient going to relapse into mania or depression? So the question is there a way to predict? The answer is yes. But actually, let's first look at the course. What happens first? This is a study we were involved in terms of, this was a 4-year study. What you can see here is in yellow or brown, relapse to depression. And this dark blue is relapse to mania. This is relapse of any kind. So, and these are patients who were hospitalized with a manic episode. So as you can see, that if there's going to be a relapse to depression, it happens early on. So and this is also why family history is important. In their family, is it mostly depressions or mania? And then once the patient is discharged, watch for depression. So once the patient recovers, should you see the patient in 3 months? No, much earlier than that, because there is a risk, as you can see here, within a good 20% relapse within 2 months. So you need to keep an eye on those patients after their discharge early on, because you're going to have the depressions. Now, the mania takes a little longer, and this were patients hospitalized with mania, I must emphasize. But still, the risk of depression is higher. Now, this is another interesting analysis. This is, and all of this is in first episode, comparing patients with manic or mixed episodes. So the question is, should I differentiate? The answer is yes, because it can predict the risk. So this is in patients where the risk of having mania is larger if the episode of admission was manic as opposed to mixed. Now, in patients who had a mixed episode, the risk of depression is higher than the risk of mania. So key point, first episode mania, were mixed features present or not? If the answer is yes, that is in the mixed patients, the risk of relapse into depression is going to be higher So if you worry about self-harm, pay more attention to those with had mixed symptoms during the manic episode. Now, this is, of course, in general. If you tell me, well, I had a patient who that didn't happen, of course, I believe it. So this is, of course, in general and on average. Other predictors of relapse is psychotic features. After recovery, is the outcome going to be worse if the patient had psychotic features or not? And the answer is high risk of relapse, comparing those with those with psychotic features compared to those without. Alcohol also increases the risk of relapse. This is using alcohol before the episode. So that also will put your patient at risk or in a group of higher risk. Okay, now this is an interesting one. The premorbid occupational status, the job the patient did before having the episode. And as we can see here, those with a lower occupational status, let's say a blue collar, have a high risk of mania compared to high occupational status, which is depression. Is it biological? Probably not. It is psychosocial factor, more likely. This is another key point. Many times we say, well, the patient was diagnosed as psychotic depression, and why is and then now the diagnosis is different. Well, it happens, as we know. So having depression later is a risk of developing bipolar. So with all your patients with depression, always check family history. And if there's bipolar, be aware that that increases the risk because there's a diagnostic shift. For that matter, most bipolar patients, the first episode is depression, not mania. First onset more frequent is mania. So that's why you do the diagnosis retrospectively. And then when do you have the conversion to bipolar? There's some bipolar types. That includes the earlier the onset of the depression, the higher risk of bipolar. The other one is mixed features, as mentioned before, and psychotic features. When you have psychotic depression, the likelihood of conversion into bipolar is high. So you can see here a study that we were involved. So these are patients with psychotic depression. Almost half changed diagnosis. So 60%, this is first episode of psychotic depression, kept that diagnosis at 2 years. But 40% change. Change to what? Well, then you know the answer, to bipolar disorder in the majority of cases, 70%. And a number of them schizoaffective. So then again, when we see a patient at PES, well, it was diagnosed with psychotic depression now, is schizoaffective now. Was the diagnosis not properly made initially? No, the answer with the data that was available, it was psychotic depression, but within 2 years, you're going to see bipolar or schizoaffective in up to 40% of patients. 70% change diagnosis. And again, we have the risk factors labeled mood. And in this case, in psychotic depression, this is key. Look at mixed features. Obviously, the mixed features in depression is mania. So if the psychotic depression has mixed features, meaning of mania, that increases the risk. So this is kind of a key indication. Maybe psychotic depression should be just a provisional diagnosis, since the majority changes, or almost the majority changes diagnosis. So that's, and actually this is something that I've always applauded about DSM-5, the mix feature specifier in DSM-4 only applied to bipolar, but in 5, it applied to depression. So that way, if you diagnose, that gives you an alert. Now, as we know, DSM-6 is going to start at some point soon, so that'll be interesting. Substance use disorder, as we mentioned a few times, highly comorbid. How frequent? This is at hospitalization, as you can see. Alcohol 24%, drug use 17%. How about medical comorbidities? High, as you can see, 31%. And then if you combine the different comorbidities, first episode, the majority of patients have some type of comorbidity. So comorbidity is a rule rather than the exception. So always make sure that you diagnose as comorbidity. Now, is it cause or effect, substance use and bipolar? I think it's bidirectional, but many times it starts before the hospitalization. But in the majority of cases, it's not. So this is a publication 20 years ago, but already an interest in early intervention. Because at first episode, we saw 17, 18%, and then 2 years later, up to 40%. And if you follow patients, and it's also usually multiple substances, but if you follow patients for more than 4 years, that is a majority, more than 60% suffer from substance use. So this is, of course, an opportunity for preventive intervention because the patient is at high risk. Are there predictors that there's going to be comorbidity? The answer is yes. When you have, in addition to bipolar anxiety disorders, that predicts substance use. Attention deficit, also highly prevalent, that predicts substance use. So this is the prevention that we're talking about, education. All bipolar patients are at risk, but especially those with anxiety disorders and those with attention deficit disorders. The use of substances worsen outcomes. Many of our patients suffer substance abuse, so at every visit, they'll tell me, well, yeah, marijuana helps me sleep, reduces my anxiety. I tell the patient, I believe you, it does, but be aware that it also increases the risk of relapse. So they have an impact. And also, when patients with substance use, the severity of the condition is higher compared to those with substance use. Suicide, major risk in bipolar disorder. Bipolar disorder is as lethal as many other medical conditions. Bipolar disorder is the most lethal of all psychiatric conditions. And first episode is a period of risk. So always keep that in mind. So this is a study that we were involved looking at suicide, recently published by a colleague, Salvatore. And this is actually looking at suicide risk in affective and non-affective psychosis, close to 500 patients, and looking at early predictors. So as mentioned, 400 patients followed for a number of years, over 10 years. And of course, DSM changed from 4 to 5, and do a best estimate procedure is not only you do the instrument, but also get collateral information. So overall risk is 20%. It's very high, and this is of suicide attempt. It's very high. And the key thing, it occurs closely to initial hospitalization and after. We know we have a metric. Was the patient followed 7 or 30 days after being discharged? And the patient should, because it improves outcomes because of the high risk of suicide after being seen at PS or being seen or being discharged from the unit. In getting back to the study, many of these cases had attempted suicide before their first hospitalization. And this is very interesting. And this is, again, psychosis, affective and not affective. The one with the highest risk is psychotic depression. So again, you see a patient at PS with psychotic depression, first episode, worry about suicide risk because it's the highest. The next one is bipolar depression, bipolar mix. Actually, bipolar manic, if you look down here, is psychotic depression is 4 times as high the risk as bipolar mania. And interestingly, the non-affective psychosis have a lower risk of suicide attempts or completed suicide than those with affective psychosis. So again, a lot of attention after we discharge from PS or when we discharge from the unit. That is why the early clinic with the great leader, Dr. Ortiz, patients are seen following the CCBHC model when they need to be seen, when the patient needs to, and after a first episode of psychotic depression or mania, the risk of suicide is high. So patients should not be seen 3 months later. They should be seen ideally 7 days and 30 days. CCBHC model. This is a history of these patients. Many of these patients with first episode psychosis, and again, we're talking about the same study, had a previous suicide attempt. So this is well known. The past predicts the future. So if it's first episode psychosis, if they had psychosis in the past, even before developing psychosis, of course, the risk increases. So this is predictors of a suicide circa the first episode. And as you can see in the next slide, it varies in the condition. But when let me actually move here. When you have schizophrenia as first episode, sort of reckless behavior is associated with a suicide attempt. When there's been violence, and actually when you look at patients with mania, it's again reckless behavior, actually in all of the conditions. But even homicidal behavior, that is a risk factor, not surprisingly, because it's impulsivity, not only with bipolar, but with schizophrenia, you see much higher. So the predictors of suicide risk vary depending on the diagnosis, and that's in this recently published study. So clinical implications of the suicide risk is, of course, close assessment of patients. Patients need to be seen as much as their condition dictates. Emotional states, it's a predictor. And of course, also prior attempts and lung prodromes also appears to be a higher risk. Now, we need to develop an intervention. This is a group by the ISBD, when the consensus of the so-called expert was we need to have a consensus of what are the interventions and starting at onset, early course. And we need to think of an illness as a continuum. The risks initially may be different than later on. And actually, the interventions could be even considered during the program. So this is the whole recommendation of ISBD, International Society of Bipolar Disorders, interventions early on. But another key thing is coordinated care. So the early clinic, those of you residents in the audience, I very much recommend rotation there. And it's coordinated care. Coordinated means that it's not only the prescriber, us, the attending, or the resident who makes the decision. It has to be the patient, it has to be the family, and also multidisciplinary. That is coordinated care, and the studies have shown that that is what's best for patients. In many cases, patients with bipolar disorder, they receive non-specialized case. That's of course, it would be difficult for everybody to have specialized case, but when it's there, use it. So we have the early clinic in the state. So that's why our goal is to take care of as many patients in the state that we have, not only including those with schizophrenia, but also with first episode mania. The key thing is to standardize the treatment. And then comprehensive care, meaning multidisciplinary and including of the family, is what best addresses complex needs. So we need treatment guidelines, and there's a new instrument. We're collaborating with the development of this instrument. It's called STRIDE, and it is not an acronym. The creators in Minnesota, I guess, came up with this term. I always wanted to find out the acronym, and there is no acronym. So we are working on this. Again, colleagues from Minnesota, Miley, David Bond from Hopkins developing this instrument. And there is, those of you familiar with the early clinic, there's Stride, that is for schizophrenia. But of course, early treatment of schizophrenia is different than for bipolar. In schizophrenia, you don't think of lithium. And in schizophrenia, you don't think of lumateperone. Well, you might have lumateperone, but cariprazine or other medications. So that's why we need something different from the one that is used in schizophrenia. Navigate. So we need Stride. And then it's not only medication, it's psychotherapy, social support, education, designed specifically for early stage patients. And in this case, Stride is for bipolar disorder. It has, of course, medication. We're not going to talk about just briefly about medication. It also the types of therapy, family education, vocational support. Early interventions studies have shown that they're quite promising, including family involvement. Always get the family involved in the care. Actually, today I saw a patient, and it was the second time I mentioned to the patient, I want to make sure that you bring your significant other. We need to do prevention, risk prevention, and also get collateral information. So that is key. So evidence of the psychological intervention, there is evidence, same as for pharmacological intervention, psychoeducation. Millay and their group have done studies, CBT, family focus, and although not all the studies are conclusive, so this is an area that needs to continue to be studied. Psychoeducation, studies conducted, colleagues in Barcelona, and it does seem to help, as you can see, when there's psychoeducation, the number of recurrences, and they still definitely diminish. So there's evidence that psychoeducation is helpful. But again, the data is heterogeneous and it's inconclusive. We mentioned education. Pharmacological challenges. Now, should we intervene in the prodrome? The answer is no, or not always. Sometimes maybe, because some individuals won't develop the condition, and medications, all of them have side effects, and sometimes they can trigger mania. So we need to be very thoughtful if we started at the prodrome or not. So of course, these are the goals: mania, depression, treat comorbid conditions. Sometimes we just focus on the mania and the depression, forget comorbid conditions. That's why the dual diagnosis clinics are so important. We have the one at ASAP. We need to develop one at the psych center. Side effects. The drugs that are used for severe mania, you can't use them long-term because of the side effects. A good example is olanzapine. We use it with severely agitated. Long-term, not a good idea because of the weight gain. And then again, focus on psychosocial functioning. Valproate, interested to see what our perinatal colleagues have to say. I know they agree with this, but it's a risk in females of reproductive age, because causes not only malformations, also polycystic ovaries. There's lots of studies that have shown the teratogenic effect. And of course, many of our first episode patients at a young age, at an age that they frequently, of course, become pregnant. So high risk. Lithium, this is very interesting. We all know that there's neuroprotection. Colleagues in Australia did this very interesting study. Probably one of the most effective mood stabilizers, in addition to lithium, is quetiapine. So they did a mano, lithium versus quetiapine. And of course, we know that bipolar worsens over time. There's loss of volume over time. So they looked at neuroimaging. And this is quetiapine, loss of white substance. This is lithium. Now, this is just one study. This has to be repeated, but quite interesting. Should we think of lithium early on? Yes. but again, with some selected patients. But this is a very interesting study that, of course, we hope that larger studies take place. Injectables should be considered because, of course, I've mentioned before, when patients relapse, it's many times it's because they're not adherent. It has worse outcome, as I mentioned, poor adherence with first episode. So we should be consider them early on. There's studies that show better outcomes, and more stable levels rather, because patients sometimes forget their medication, and it is underused. Should it be at first episode? Maybe in a very selected case, it should be mentioned. And we've mentioned at the early clinic, and some patients are interested right away. So it should be considered. But of course, shared decision, patient makes a decision. Of course, the family, we provide the information. Nowadays, for bipolar, it's only used for the non-adherent patients. There's stigma attached. Patients say, no, this is not a schizophrenic patient, it's bipolar. Of course, using that terminology as a stigma. So it should be considered. Now, problem with the LAIs, Haldol, it's approved, but it causes depression. Olanzapine, not approved, and weight gain, so wouldn't be recommended, certainly at first or second choice. Risperidone doesn't prevent depression. Aripiprazole doesn't prevent depression, so the use of LAIs is limited. Here we have the indications. We're wrapping up here as you can see, lots of medications with mania. Which one is the best? The answer, whichever is best for your patient. So we have a number of them mixed, less in maintenance. Actually, of the ones recently approved for bipolar depression, unfortunately, none for maintenance. And as you can see, LAI, just the two that I've mentioned. So treatment gaps, more studies. We need to develop the guide. And which one is, we need more studies. We need to focus on functional recovery. So summary, early symptoms resemble disorders. Risk is genetics and environment. Timely intervention is key. Practice preventive medicine, and understanding the conditions before will better lead us to more preventive treatment. And the goal is not just to stabilize the illness, but preserve the functioning for future well-being. So with this, folks, thank you for your attention. Dr. Varela, we just left a couple of minutes for questions, but shoot.
Dr. Tohen, I think Dr. Varela had to leave early.
Oh, so it's the illustrious Dr. Waldorf taking over. Great.
I'm not sure about illustrious. Thank you so much. So really, such important information, and for somebody who treats young adults with substance use disorders, the comorbidity factors, very interesting to me. Other folks' comments or questions for Dr. Tohen?
And I don't want to hold you folks. Please reach out to me with any questions. Those of you who don't have obligations, certainly with patients, please do stay. I can stay for as much time as we have questions. Those of you.
So I have a question. Can you hear me?
I can hear you, Dr. Bustillo, please.
All right. Well, thank you so much, Dr. Tohen. That was very, very interesting. So, in terms of the prodromal symptoms in children, I mean, you remember the issue of the increased diagnosis, like six-fold diagnosis of bipolar disorder in children before, like 15 years ago. It was an epidemic of bipolar disorder in children, and there was a lot of focus on, irritability in children and whether this is prodromal. And the studies at NIMH by a child psychiatrist, Liebenfeld, I remember, led to the diagnosis of, I think it's called disruptive mood
dysregulation disorder.
Disruptive mood dysregulation disorder.
That's the problem with acronyms. We don't remember the spelling.
Yes, yes. But so, And the bottom, what I recall from those studies is the bottom line is that these children that have irritability and who you could be constructed as bipolar, they really do not have bipolar disorder. And that was literature like 15 years ago. So do you think that follow-up studies, have there been any follow-up studies that support the thesis that DMDD is not bipolar disorder and those kids should not be seen as bipolar disorder, or has anything changed?
Actually, that is an area of major controversy to the point that you have a team saying that they follow that theory and another team as large that does not. So to answer this your question, no, there has not been studies to long term. They obviously have to be long term to prove. I think what most people agree is that there's going to be a population that have similar symptoms that doesn't continue in adulthood, and some that do. The problem with, well, not the problem, but knowing that there's a condition that will not continue in adulthood it gives you a lot of hope. It's great to have because then you start hoping that it's going to be a DMDD as opposed to bipolar in young age. I think it does exist, but do you have bipolar disorder at young age? The answer is yes. So I think there's room for both, Dr. Bustillo.
Yeah, but I mean, the point that I think Liebenfeld pushed and her data pushed
Yeah.
was that unless the kid has a clear episode of mania or a clear episode of depression, that is not that it's very low the chance that the kid is going to develop a bipolar disorder. Once there's an episode, yes. Yeah, again, this data was 15 years ago, and so it sounds like you think that there's still the researchers are not persuaded, the majority of them, that that's the case.
I would say that a good majority, and actually there would be another example of conversion, that the DMDD having a conversion to bipolar. I guess that would be one way to look at it.
All right,
But
thanks.
thank you, Dr. Bustillo. Harrison Grace.
All good. Yeah, thank you, Dr. Bustillo and Dr. Tohen. I guess many questions to continue picking y'all's brains another day. But yeah, I do, from my own limited anecdotal experience, do note a lot of that underlying, DMDD type, or more commonly an unspecified trauma, developmental trauma type picture behind what brings people in for initial concerns of irritability. I think that my question is how to approach the kind of problem of not having retrospect. I think it's almost unavoidable that initial rare presentations of disorders are hard to pick apart in the moment and sometimes get lost to follow-up, especially with the transition from child psychiatry to adult psychiatry threshold. Any approaches in general that you've seen systemically or recommend in general?
Yeah, no, I think again this is why collateral information is helpful. This, of course, can be a recall bias that let's talk about family history. If let's say there's a patient who has siblings who initially developed the MDD and then did not, let's use the word convert to bipolar, and your patient is in a similar condition. In that case, I think the likelihood that there's going to be no conversion would be higher had the siblings not been described by collateral information. I think also a key thing is treatment. I guess DMDD, by definition, symptoms will not convert into bipolar. So then do you think about, that's an important decision in terms of tolerance. But you made another key point, Dr. Grace, which is PTSD. PTSD is almost ubiquitous with bipolar disorder. Studies have shown or actually more than PTSD, is a history of abuse. It's up to 40%. Studies have shown 40%. So is it PTSD that you're seeing, or is it a combination of both? And you see both. But I think a key thing is treatment, and get collateral information that will help you predict the possible outcome. Not sure yet that answered your question, Dr. Grace.
Yes, thank you.
Other comments, folks? Questions? Well, thank you again for attending Grand Rounds. Have a great weekend. So long.